You know that feeling, right? When your pet just seems a little off, maybe a bit lethargic, not eating quite right.
Oh, yeah, that little worry owners get.
Exactly. And sometimes those small signs can, well, they can escalate really fast when it comes to their health.
They absolutely can. Our pets can't just tell us what's wrong, so those subtle shifts,
hmm
sometimes they hint at something bigger going on.
Which brings us nicely to today's deep dive. We're going into some conditions that are thankfully quite rare, but really serious. Bacterial infections affecting the central nervous system, the CNS, in dogs and cats.
Right. We're talking meningitis, meningoencephalitis, and meningomyelitis.
Okay, let's break this down a bit. Meningitis, that's inflammation of the meninges, right? The protective layers around the brain and spinal cord.
That's the one. And if that inflammation then spreads into the actual brain tissue,
Then it's meningoencephalitis.
not
Okay.
bad.
And the last one, meningomyelitis.
That's when the inflammation involves the meninges and extends into the spinal cord itself. So you see, they're all related, affecting slightly different spots, but causing potentially similar issues.
Okay, hearing brain and spinal cord infections definitely sounds scary. So let's stress up front, these are rare in pets.
Very important point. They don't happen often.
But their rarity doesn't make them any less critical to understand. You know, how they happen, what signs to look for, and frankly, how tricky they can be for vets to diagnose and treat.
Absolutely. That's the goal today, isn't it? To pull out the key info, shed some light on these conditions.
Right. Our mission for this deep dive. So, first things first. How do bacteria even get into such a well-protected place like the CNS?
Good question. There are a few main roads. One is direct extension, meaning
hmm
if there's an infection really close by, like a bad ear infection, maybe in the eyes, sinuses, or nasal passages, if it's severe or not treated
It
properly.
can spread next door, so to speak.
Yeah, exactly. The bacteria can sort of push through the natural barriers and get into the meninges.
Okay, that makes sense. Like a fence breach. What else?
Then there's penetrating trauma, less
Mm,
common, thankfully.
Like a deep wound.
Yeah, or even something migrating inwards. Think nasty grass-awns, maybe even porcupine quills ending up where they shouldn't. That can introduce bacteria directly,
Ouch. Yeah, you can imagine that causing problems.
definitely. But probably the most common way, especially in, say, septicemic newborns or really immunocompromised animals.
Septicemic meaning infection in the bloodstream.
Right, a serious bloodstream infection. In those cases, it's often hematogenous spread.
Hematogenous meaning through the blood.
Precisely. Bacteria traveling through the bloodstream from an infection site somewhere else in the body. The bloodstream acts like a highway.
So an infection, totally unrelated location-wise, could lead to a CNS infection, like from the gut.
Potentially, yes. Or maybe bacteria that normally just live on mucous membranes take advantage. Or there's a distant infection that wasn't obvious. It's a big risk in newborns with infections, or any animal whose immune system isn't firing on all cylinders.
Okay, so the bacteria get into the meninges, those protective layers. But why does that cause such serious neurological issues? What happens next?
Well, the inflammation in the meninges is a problem itself,
Mm-hmm.
but often it doesn't stop there. That inflammation can then spread into the underlying brain or spinal cord tissue, the parenchyma.
Ah, so it jumps from the lining into the actual nerve tissue.
Exactly. And that's what directly causes the neurological deficits we see. It's like the fire spreading.
And I imagine inflammation in such delicate tissue, well, it's bad news.
It is. Plus, the body's response, all that inflammation creates debris. And over time, you can get scarring.
It's okay.
And that debris and scarring can actually block the flow of the cerebrospinal fluid, the CSF.
The fluid that cushions everything.
Right. If that flow gets blocked, pressure can build up. You can get what's called secondary hydrocephalus, basically, excess fluid on the brain.
Wow. So it's the infection and the body's reaction causing problems?
It's a double whammy, really.
So who gets these infections? Is it just dogs or cats too?
Both. Dogs and cats can both be affected.
Any particular age, like puppies or older pets?
Nope. It can happen at any age, really,
Right.
from the very young right through to senior animals.
Okay. And what about males versus females? Any difference there?
Doesn't seem to be. The data suggests males and females are affected pretty equally. Sex isn't really a predisposing factor here.
All right. So we know how it can happen, who it affects, but what are the signs? What should owners be watching for? What makes a vet think, could this be a bacterial CNS infection?
Well, first off, these animals are often systemically ill. It's usually not just one weird neurological sign in an otherwise healthy pet.
Meaning they seem sick all over.
Yeah, like general depression, lethargy, maybe not eating. In really severe cases, especially with that bloodstream infection, septicemia,
Yeah.
they can be in shock. low blood pressure, maybe even DIC.
DIC, what's that?
Disseminated intravascular coagulation, a really serious clotting problem where the body makes tiny clots everywhere and then can run out of clotting factors, leading to bleeding issues.
Yeah.
It's bad. And the CNS signs themselves, they can be quite severe and often come on fast.
Rapidly progressive.
Yeah, that's uncertain.
What specific things might someone see?
On a vet's physical exam, about half of them will have a fever. A really classic sign, especially with meningitis, is cervical rigidity.
A stiff neck.
Exactly. Painful, reluctant to move their head. And they might show hyperesthesia, increased sensitivity to touch, particularly around the neck. Just uncomfortable being handled there.
Makes sense if the linings are inflamed. What about the purely neurological stuff?
That really depends on where in the brain or spinal cord the inflammation is. You might see changes in their mental state. Dullness, confusion, disorientation.
Not acting like themselves.
Right. Or issues with cranial nerves, think facial drooping, trouble swallowing, weird eye movements, problems with posture, balance, what we call ataxia.
Like they're drunk or wobbly?
Kind of, yeah. Uncoordinated. Weakness, paresis, or even paralysis in the limbs can happen. And seizures are definitely a possibility if the brain's involved.
Wow, that's a huge range. Sounds like it could look like a lot of different things.
It absolutely can, which is why the vet needs to look for other clues too, like an underlying infection elsewhere. Some might be vomiting. And in severe cases with high pressure in the skull, you might see a weird combination. A slow heart rate, bradycardia, but with high blood pressure, systemic hypertension. That's a worrying sign of increased intracranial pressure.
Okay, that's a lot to watch for. Let's circle back to the causes. We talked about the pathways: direct spread, injury, blood. Are there typical triggers for brain inflammation versus spinal cord?
There are some general links, yeah. Meningoencephalitis, the brain and meninges.
Yeah.
That's often tied to that direct spread from nearby structures.
The ear, eye, sinuses again.
Exactly. Or direct contamination from trauma, like a skull fracture, or those migrating foreign bodies we mentioned, like grass-awns.
And meningomyelitis, meninges, and spinal cord.
That's more often linked to spinal issues.
Yeah.
Things like discospondylitis.
Infection in the discs between the vertebrae.
Right. Or vertebral osteomyelitis, which is infection in the bone of the vertebrae. The infection can spread from the spine to the nearby meninges and cord.
And the blood spread, hematogenous spread, what kind of infections elsewhere could lead to that?
Well, in newborns, omphaloflebitis infection of the navel is a known starting point.
Okay.
Any animal that's immunocompromised is at higher risk generally. But specific sources could be bacterial endocarditis.
Heart valve infection.
Yep. Or prostatitis in males, discospondylitis again, maybe severe pneumonia, or even really bad gastroenteritis. But honestly, sometimes, despite looking hard, we just can't find the original source.
That must be incredibly frustrating.
It really is. And just generally, the big risk factors are any untreated bacterial infection, a weakened immune system for whatever reason, and of course, injuries involving or near the CNS.
Okay, so given all the potential signs and causes, diagnosing this sounds like a real challenge. It's not always clear-cut, I imagine.
Oh, definitely not. Diagnosing bacterial CNS infections is, well, it's tough. Because so many other things can look similar. You need a really thorough workup.
A differential diagnosis list, right. What else is on that list?
A big category is other types of infections. Not bacterial, but maybe viral, like canine distemper.
Okay.
Or parasitic toxoplasmosis is a big one, especially in cats. Or neosporosis. Fungal infections like crypto or blasto. Even things like tick-borne diseases affecting the nervous system, or FIP in cats.
Wow. And do these look different in tests?
They can all cause inflammation in the CNS, so the CSF often shows inflammatory cells. Sometimes the type of cell gives a clue, but not always. You often need specific tests for those organisms on the CSF or blood, maybe other tissues.
So infection isn't always bacterial? What about non-infectious inflammation?
Yes, that's another major group. Important ones to know are steroid-responsive meningitis arteritis, or SRMA, sometimes called aseptic meningitis.
What's that?
Mostly young, large breed dogs, though not exclusively. They often have neck pain, maybe a fever, but seem otherwise okay systemically. Their CSF shows inflammation, often neutrophils, but crucially, bacterial cultures are negative.
And they respond to steroids?
Exactly, that's the key. They get dramatically better with steroids.
Okay. What other non-infectious ones?
Then you have things like granulomatous meningoencephalomyelitis, GME, or the broader term meningoencephalitis of unknown origin, MUO.
Unknown origin, meaning we don't know the cause.
Pretty much. It's thought to be immune-mediated. Tends to affect young to middle-aged dogs. Certain breeds may be more prone, like terriers, poodles. Signs vary wildly depending on the location. CSF shows mixed inflammation. Cultures are negative. Definitive diagnosis often needs postmortem tissue analysis, unfortunately.
And there are some breed-specific ones too, right?
Yes, like necrotizing meningoencephalitis, NME seen in pugs, Maltese. Affects the forebrain, so seizures, behavioral changes are common.
Mm.
And necrotizing leukoencephalitis, NLE, more in Yorkies, affects more brain regions. Again, thought to be immune-mediated, CSF shows inflammation, but no systemic illness usually.
Gosh, it's a minefield. What about brain tumors?
Yep, primary CNS neoplasia. Tumors originating in the brain or spinal cord, they can cause similar neurological signs.
How do you tell them apart?
Often the history is slower, more gradual progression with tumors. And the signs are usually just neurological, no systemic illness. Standard blood work is often normal. Imaging, like MRI, maybe a biopsy, is usually needed to confirm a tumor.
Okay, so ruling things out is a huge part of this. What lab tests help narrow it down?
We start with the basics. Blood work, a CBC, complete blood count, and a biochemistry panel. With bacterial CNS infections, you often see a high white blood cell count, maybe signs they're fighting hard like immature cells. If they're septic, platelets might be low. That's thrombocytopenia. The biochem might show effects on other organs. Sometimes high globulins proteins suggest a chronic infection somewhere. And it's coming from the urinary tract or prostate. You might see bacteria or pus in the urine analysis.
Are there more specific blood tests?
Yeah, serology looking for antibodies can help rule out those non-bacterial infections. Fungal, protozoal, viral, rickettsial. But interpretation is key.
How so?
Well, like we said, a positive toxoplasma titer in a cat doesn't automatically mean that's the cause of the current CNS problem. It just shows exposure. We might also do cytology looking at cells under a microscope from other suspect areas, like nasal discharge or skin lesions, especially useful for things like fungi. And blood culture is important, trying to grow bacteria from the blood. It's positive in maybe 30% of dogs with bacterial meningitis.
So blood tests give clues, but not always the whole picture. What about imaging? X-rays, scans?
Imaging is crucial. Chest and abdominal x-rays, maybe an abdominal ultrasound to look for a source infection. Spinal x-rays might show that discospondylitis. A head CT is good for checking sinuses, nasal cavity, ears, those potential direct spread routes. It can show inflammation with contrast. If we suspect the heart valves, an echocardiogram heart ultrasound is needed.
And the big gun, MRI.
MRI with contrast is really the best for visualizing the brain, spinal cord, and meninges themselves. It's much better than CT at showing inflammation there. It can also pick up those potential source infections nearby, like in the sinuses or ears. It gives the most detailed view inside the CNS.
Right, so bloods, imaging, but that CSF tap, the spinal fluid analysis, sounds critical.
It often is.
Yeah.
CSF analysis is key for looking directly at the environment around the brain and spinal cord. But, like you hinted, there are risks.
What kind of risks?
If there's already high pressure inside the skull signs, like altered mental state, doing a tap could potentially cause brain herniation, which is very serious.
So you have to be careful.
Extremely careful. We often pre-treat with mannitol, a drug, to temporarily lower that pressure if we're concerned.
Okay, assuming it's safe to do, what do you look for in the CSF?
In bacterial infections, the classic finding is neutrophilic pleocytosis, lots of neutrophils, a type of white blood cell, and high protein levels. The neutrophils might look abnormal, maybe even contain visible bacteria, though seeing bacteria isn't guaranteed. But just seeing neutrophils isn't proof positive of bacteria. Other inflammation can cause that too.
So the cell count isn't definitive on its own. What else do you do with the CSF?
Culture. Absolutely vital. We try to grow bacteria from it both aerobically and anaerobically. Problem is, CSF cultures are positive less than 40% of the time, even when bacteria are the cause.
That seems really low. Why?
It can be hard to grow them from CSF. We often use special broth enrichment media to try and boost the chances, but thankfully we now have PCR.
PCR, like for DNA.
Exactly. Universal bacterial PCR can detect bacterial DNA in the CSF, even if the bacteria aren't growing in culture or are already dead. It's a really valuable backup when culture is negative.
That sounds incredibly useful. What if, sadly, the pet doesn't make it? What do you find post-mortem?
We might see obvious pus collections, like a subdural empyema, or just pus coating the surface of the brain or spinal cord. Microscopically, we see widespread inflammation with pus suppurative inflammation. And importantly, cultures taken directly from those affected tissues post-mortem are positive much more often, over 75% of the time.
Okay, so diagnosis is complex. Rule out mimics with bloods, imaging, CSF analysis, including culture and PCR. Once you suspect or confirm bacterial CNS infection, how fast do you need to act?
Immediately, there's zero time to waste. These are emergencies requiring aggressive inpatient treatment, often ICU-level care.
Why the urgency?
Because the goal is to stop the infection and inflammation before they cause permanent, irreversible damage to the brain or spinal cord. Every minute counts.
So hospitalization is a must. What's the initial focus?
Supportive care is huge. 4D fluids are critical for hydration and blood pressure. Good nursing, keeping them comfortable. Strict rest is usually advised. And clear communication with the owner is vital, explaining the severity, the need for aggressive treatment, and the guarded prognosis.
Guarded prognosis meaning uncertain outcome.
Yes, hopeful, but definitely uncertain. We have to be honest about that.
And the actual medications, antibiotics are key, obviously.
Cornerstone, yes. But not just any antibiotic. The ideal ones need to be bactericidal, kill bacteria, and, crucially, get into the CSF at high enough levels.
The blood-brain barrier challenge again.
Exactly. They need the right properties.
Yeah.
Lipid-soluble, small size, low protein binding, the right charge to cross that barrier. Think of it like needing a special security pass to get into the brain.
So picking the right one is critical.
Absolutely. That's why getting those cultures, CSF, blood, urine, any other infected site, is so important to guide the choice based on sensitivity testing. But you can't wait for results.
Right, because treatment needs to start now.
So we start empirically with broad-spectrum antibiotics known to cross the blood-brain barrier well.
Like which ones?
Common choices are third-generation cephalosporins, drugs like ceftriaxone, cefotaxime, fluoroquinolones can be good, trimethoprim sulfonamides, doxycycline, metronidazole.
What about drugs like penicillin or amoxicillin?
Interestingly, drugs like penicillin, ampicillin, amoxicillin, clavulanate, they don't normally cross the healthy blood-brain barrier very well. But when the meninges are inflamed, the barrier becomes leakier and they can get in.
Ah.
So sometimes they're used maybe in combination. Ampicillin, for instance, can actually reach pretty good levels. And metronidazole is excellent, great penetration into CSF, brain tissue, even abscesses, and it nails anaerobic bacteria.
What about clindamycin or older cephalosporins?
Clindamycin doesn't really get into the CNS well enough for most bacterial infections, though it's useful for toxo or neospora. First-gen cephalosporins and aminoglycosides. Generally poor penetration, so we avoid them. Chloramphenicol gets in, but seems to have a higher relapse rate, so it's not usually a first choice.
So a very strategic choice of antibiotic. How are they given initially?
Usually IV intravenous for the first few days, 3 to 5 maybe, to get those CSF levels up fast. Once the patient is improving and stable, we can often switch to oral meds for the long haul. Sometimes, if the initial CSF smear gives a clue like gram-positive versus gram-negative bacteria seen, we might tailor the initial IV choice even before cultures are back.
Makes sense. Besides antibiotics, what else is used?
If there are seizures, definitely anti-epileptic drugs, maybe diazepam 5E for active seizures, then something like phenobarbital for maintenance.
Okay.
And corticosteroids, like dexamethasone, are sometimes used short-term.
Steroids to reduce inflammation?
Exactly. The idea is that a lot of the damage comes from the body's own inflammatory response. So maybe a dose before the first antibiotic, then perhaps every 12 hours for a day or two to try and dampen that initial inflammatory cascade.
So antibiotics, seizure control, maybe short-term steroids. What about follow-up once they start getting better?
Constant monitoring is key. Watching neurological signs, temperature, white count, overall demeanor. Owner education for home care is vital. Finishing the entire antibiotic course is non-negotiable. And prevention involves treating those potential source infections, ears, eyes, sinuses, spine early and effectively.
Even with all that, are there still potential long-term problems?
Unfortunately, yes. Even with the best care, irreversible damage to the brain or spinal cord can occur, leading to permanent neurological deficits.
And the overall prognosis, what's the typical outcome?
It's variable. Response to treatment differs, but overall the prognosis is considered guarded. Sadly, many patients don't survive despite intensive treatment. Those that do pull through might have lingering issues, and treatment needs to be long, often at least 4 weeks after all signs have resolved, to minimize relapse.
Wow. It really sounds like a tough battle for everyone involved, pet, owner, vet team.
It absolutely is.
Ah.
But early recognition, aggressive treatment, it does give them the best possible chance. Some do make good recoveries, but it's often a long road.
Well, wrapping up this deep dive, I think the huge takeaway is clear. Bacterial CNS infections, while not everyday occurrences, are incredibly serious. We need to be alert for those early, maybe subtle signs and get veterinary help immediately if we're worried.
Absolutely. And it really underscores how complex diagnosis can be, needing that expert veterinary approach to sift through all the possibilities other infections, non-infectious inflammation, to find the right path.
It really does. Which leads me to a final thought for everyone listening. Thinking about how interconnected the body is, it makes you wonder what other seemingly small, localized infections could potentially spiral into something much more severe if left unchecked.
That's a great point.
It's just a good reminder, I think, for all of us pet owners to stay proactive, address those minor issues promptly with our vet, because you just never know what might be brewing under the surface.